Hi everyone, welcome back to the Critical Care course. This is Rebecca with Archer Review. Today we're kicking off the neurological module. So what a better place to start than going over neurological anatomy and physiology, where we're going to talk about the central nervous system, the peripheral nervous system, as well as the autonomic nervous system. Just get a good basis of understanding for that A and P so that when we get into the disorders of the neurological system, we are equipped to understand them. So let's get started simply here with the cells of the nervous system. The two that I've listed here that are primarily important are neurons and neuroglia. So neurons use electrical and chemical signals to transmit information. They are electrically excitable, kind of like cardiac cells in that way. They connect to other neurons at synapses sites. And in the periphery, the cells are coated by endoneurium and other layers, and that's what creates nerves. And nerves allow the central nervous system to communicate with the peripheral nervous system. Neuroglia are supportive and protective cells in the nervous system. They are the most abundant cell type. We have oligodendrocytes and Schwann cells. Oligodendrocytes are responsible for myelin production in the central nervous system, and Schwann cells are responsible to create myelin in the peripheral nervous system. Myelin creates the myelin sheath on the neuron, and we can see it here in this diagram here. There is no transport of impulses from one ending to the next, from one nerve to another, from one neuron to another, without myelin. This sheath is absolutely critical to a neuron working the way it's supposed to. So neuroglia are responsible for creating that myelin. They play a huge role in neurons functioning the way they're supposed to. Let's dive into the central nervous system. The central nervous system is made up of the brain and the spinal cord. This slide here is dedicated to the brain. So we've got layers to our brain, starting with the skull, which is the outer hard protectant. Then we have the meninges, which surround the brain and exist under the skull. We've got a few different layers there in the meninges, the dura mater, arachnoid matter, and pia mater. Dura mater is a tough layer that exists directly under the skull. The arachnoid matter is directly under the dura mater, and it is a soft tissue membrane. And directly under that arachnoid matter is a space called the subarachnoid space, where CSF, or cerebrospinal fluid, flows freely. Then following that layer is the pia mater, which is directly above the brain tissue itself. It's highly vascularized. This is a key way that the brain is fed with oxygenated blood. In addition, we also have a ventricular system within the brain. These are 4 inner brain chambers that contain CSF, or cerebrospinal fluid. They're basically like buckets where their whole job is to store that cerebrospinal fluid. Structure-wise, we have bilateral hemispheres that are connected by the corpus callosum. Then we also have multiple lobes: frontal, parietal, temporal, and occipital, and those are all imaged here to the right. Cerebral circulation I want to talk about real quickly. How does the brain get any blood flow? We have arteries, internal carotids here on the neck on the anterior side, and vertebral arteries on the posterior side provide the brain with oxygenated blood, so it's all coming up through the neck. We do have a circle of Willis that sits at the base of the brain, and it houses blood in the presence of arterial occlusion. If we were to put pressure on both of our internal carotids here, we would really obstruct blood flow to our brain. But luckily, there is storage there in that circle of Willis to supply the brain with oxygenated blood, again, in case there is any issue getting fresh oxygenated blood up to the brain. The jugular veins are primarily responsible for drainage. They're draining deoxygenated blood from the brain, and those jugular veins go right alongside those internal carotids. We have internal jugulars and external jugular veins. And then I want to briefly talk about the blood-brain barrier system. This system, it's a semi-permeable membrane that exists on the blood vessels in the brain, and it stabilizes the environment surrounding neurons. Contains physical and chemical barriers. And basically, its whole goal is to ensure that not everything in the bloodstream makes it into the brain tissue where it can affect neurons. Neurons can be more sensitive to pathogens and different substances that might be in our blood that the rest of our tissues can handle and fight off. The neurons might not be able to. So the brain has built in these extra vessel wall layers on the blood vessels to ensure that not everything can just pass over by diffusion into the brain tissue. It's a lot more protective of a space. Continuing with the central nervous system, let's talk about the spinal cord. The spinal cord is protected by the vertebral column, which is all bone. That's our spine. And it's also protected by the meninges. And it's the same meninges that extend down from the meninges surrounding the brain. And they're called the exact same. We have dura mater, arachnoid mater, and pia mater, all protecting our spinal cord. We have spinal nerve segments, including cervical, thoracic, lumbar, sacral, and coccygeal. And I really love this graphic that we have over here to the right. It tells us exactly what each spinal nerve segment is controlling in the body. So this way we can start to think about spinal cord injuries. If we have a spinal cord injury in C2, for instance, we can anticipate that that client is going to need assistance breathing because their diaphragm is going to be affected by that injury. So that's a significant injury because they might be dependent on a ventilator to help breathe for them. So we can use this map to determine the effects of a spinal cord injury on that client's function. Next, let's talk about the peripheral nervous system and the structures within that. We have the somatic nervous system, which is responsible for voluntary movement. That somatic nervous system is carrying impulses from the central nervous system out to the peripheral nervous system to allow for us to pick up a cup, for instance, or do anything voluntarily. Within the peripheral nervous system as well are cranial nerves. We have cranial nerve 0 all the way to cranial nerve 12, and I've got them all listed here to serve as a reference for which cranial nerves control which movement. And finally, I want to talk about the autonomic nervous system. So we've talked about the autonomic nervous system in plenty of modules so far, both respiratory and cardiovascular. Something to consider when we're talking about critical care is that our clients are in a state of stress just by the fact that they are critically ill. A lot of our clients are going to be actively controlled by their sympathetic nervous system versus the parasympathetic nervous system. So circling back, what is the autonomic nervous system? It's regulation that occurs without conscious control. This is not voluntary at all. And it includes two different types of systems. Like we said, the sympathetic and the parasympathetic. What I want us to remember is the sympathetic nervous system is what takes over in any stressful condition. Whether that is fight or flight, we're handling an external threat, or the sympathetic nervous system can also kick off when our body is fighting illness within itself. And that's why I said, again, a lot of our clients are being controlled by the sympathetic nervous system. Main things to remember about that sympathetic nervous system is that alpha and beta receptors are stimulated. Once those are stimulated, it causes increased cardiac contraction, particularly by the beta receptors being stimulated, blood vessel constriction, particularly by those alpha receptors being stimulated, bronchial dilation, those are when beta 2 receptors are stimulated, decreased peristalsis, bladder relaxation, urinary sphincter contraction, pupil dilation, increased sweat, and increased epinephrine secretion, which is a steroid out of our adrenal glands. Every single one of these actions that takes place in the sympathetic nervous system is all about increasing blood pressure to our primary organs, increasing perfusion in that state of stress, and giving the body the best chance to fight something off. The parasympathetic system, like we said, takes over in restful situations, and it causes pretty much the opposite of the sympathetic nervous system. So we're going to see decreased cardiac contraction because the heart is at rest. It doesn't need to pump super significantly hard. Bronchial constriction, increased peristalsis. Now we can prioritize gut motility and that sort of thing that we won't prioritize in a stress response. Bladder contraction and urinary sphincter dilation. The way that I remember that sympathetic is for stress and parasympathetic is for rest is I just think about when I have a friend who is stressed out and they're going through something, maybe they've got a lot going on in their life and they're highly stressed out and they're talking to me about it. The first thing I want to offer them is compassion and sympathy. I want to talk to them about what's going on. I'm feeling sympathy towards them while they're actively in stress. So I remember sympathetic nervous system is stress. Parasympathetic is the opposite, it's rest. Hi everyone, welcome back to the Critical Care course. This is Rebecca with Archer Review. We're continuing through the neurological module today. So we're going to talk about performing a neurological assessment in the ICU. So let's get started where we always do, here with a history. We want to assess for our client's baseline neurostatus. This can sometimes be a little bit difficult in the ICU, especially if our client is not in a state where they can speak to us. Let's say they came in to the emergency room or came in via an ambulance. They were instantly intubated, put on a ventilator. They're now on sedation. We're not going to be able to assess their current neurostatus super well or what their baseline neurostatus. This is when it's super helpful if the client has any family or friends that are coming to visit them. It's very appropriate to say, hey, I have had this client while they've been sedated. I have not been able to talk about what they look like normally. What do their function like? Are they able to move around independently in the home? Do they communicate well? Do they have any previous history of stroke that could have left some residual effects? We can absolutely ask family and friends that visit that client what they looked like prior to this hospital admission when we aren't able to ask the client themselves. Sometimes the client's not sedated, but they're still not a great historian to what they may have looked like prior to coming to the hospital if their neurostatus has been tremendously affected. Let's say they come in with a stroke. They might no longer have certain memories of what their life used to look like. We have to consider that assessing a client's neurostatus, and we see them in the hospital and there's already been certain amounts of damage done, we might not really know what they would have looked like before, which makes it very difficult to assess the extent of their current injury. If we are able to talk to the client or a family member, we want to ask about symptoms of their present illness. When did they start? How did they progress? The chronology of the event. I want to make a note here talking about stroke. Timing and nature of symptoms assessment is key for treating stroke. So asking a client or a family member for any information is critical when the event itself is not witnessed. So when a client presents to the emergency room with stroke symptoms, typically somebody's bringing them in or an ambulance was called. We want to find out when those symptoms started. It gives us a lot of information before we go about treating a stroke. We need to know when those symptoms started. Windows are very important. Last known well times are very, very important. So any information we can get about the symptom progression and the event is super important when it comes to treating our clients with neurological consideration. We want to know of any comorbidities, any medical history, family history, contributing factors like medications, specifically anticoagulants. If we know that our client is on warfarin, maybe for atrial fibrillation, and they fell in an assisted living center, maybe hit their head, we would really want to know if they were on anticoagulants, right? Because that would significantly increase our risk for hemorrhagic stroke. Another pertinent medication would be diabetes management. Is the client hypo or hyperglycemic? Those have tremendous neurological effects. And finally, we'll assess pain. That is absolutely a part of our neurological assessment. For this critical care course specifically, we actually have a whole module devoted to pain, so you'll see more about pain assessment over there. So let's dive into a focused assessment. Now, I want to say here that the neurological assessment is quite different than any other body system. We're not really palpating or auscultating or percussing. We're doing a lot of inspection, a lot of communication, and taking the client through different processes to see what their neurological function looks like. But like I said, this neurological focused assessment will not look like your other body systems. So first, we want to get an overview of their mental status. This includes level of consciousness and arousability. So arousability or level of consciousness is referring to how much stimulation is this client requiring for us to get their attention and then be alert to us. Are they awake upon assessment? We enter the room, they're already awake. That's a highly arousable client. They're alert. Are they requiring voice stimulation? Which this can be a little difficult. Maybe your client is just sleeping and you have to say, hey, Mr. Smith, can you wake up for me? That would technically mean that we had to use voice stimulation for that client, but they might not have anything neurologically wrong with them. They were just asleep. So you have to use multiple factors to consider this. Are they a bit more sedated? Do they require light physical stimulation like shaking or tapping? Do they require painful stimulation to arouse, like a sternal rub or pinching of the nail beds? Next, we can take this down to the Glasgow Coma Scale. The Glasgow Coma Scale assesses 3 categories: eye-opening, verbal response, and motor response. It basically puts that level of consciousness or arousability into a scale form so that we can objectively treat these clients. The scores range from 3 to 15, and lower scores are indicative of reduced neurostatus. So you can see the Glasgow Coma Scale here. eye-opening if you go into your client's room and they never open their eyes. They are very, very sleepy and not arousable. You're shaking them, you're sternal rubbing, they never open their eyes. They would receive a 1 score for that. Verbal response, same thing. You go in, you're trying to stimulate them, but maybe this time they don't open their eyes, but maybe they let out a few moans or sounds. They would score a 2 for verbal assessment. Motor response. You ask them, hey, can you squeeze my hands? Can you wiggle your toes? They're not able to do that. But when you apply pressure to their nail bed, maybe they pull their hand back. That would be a withdrawal to pain. They would score a 4. That means that client is scoring a 7 on the Glasgow Coma scale. Now, looking at that client objectively and just basing things off this Glasgow Coma scale, something to note is that we say below 8 equals intubate. This is not a hard stop. It doesn't mean every single time that a client scores below an 8, we're instantly intubating them without looking at any other factor. But it is supposed to act as a trigger for us nurses and any healthcare professional for if they're performing this assessment and that number comes back below 8, we need to be thinking, okay, are they too lethargic to protect their own airway? Let's take a look at their vital signs. It kind of prompts us to be like, do we need to be thinking about intubating this client? Because their neurostatus might not be sufficient for airway protection, as well as maybe controlling their breathing patterns and getting enough oxygen in. It's supposed to just be a little trigger for us. If we do score somebody in that 8 range, we're thinking, okay, what else is going on here, and do we need to intubate this client? Let's continue with some more aspects of our focused neurological assessment. So first, we can assess our client's cranial nerves. Cranial nerves control sensation and motor function of the face, eyes, ears, and shoulders, as well as play a part in phonation and swallowing. So if I'm going into a client's room to assess their cranial nerve function, I'll start with sensation. I'll have the client close their eyes, and I will just touch lightly throughout their face and neck and have them tell me where they feel that I'm touching them. That will briefly assess sensation. You can get a little bit more in depth and use sharp tools versus soft tools and have the client tell you whether they feel something sharp or something soft. And we will do that if we are worried about something specifically. But for every single client where we're just doing a general neurological assessment, I won't typically go into that much detail with every single client. For motor function, same thing. I'm just going to do a broad cranial nerve assessment here. So I will have the client smile. I will have them raise their eyebrows and close their eyes really tight. And I'm looking for symmetry and movement here. This can also be very helpful in assessing for stroke symptoms that can have unilateral side effects. If I am concerned for stroke symptoms, having somebody do things like a smile, raising their eyebrows and closing their eyes really tight, it requires moving both sides of the face in the same way. So I can see with a smile if somebody is drooping on one side, if when they go to raise their eyebrows, one eyebrow is not being raised as much, I can see an asymmetry in their motor function, and that could tip me off to thinking maybe something else is going on. We can also assess phonation just by talking to the client. What does their voice sound like? And then have them swallow. If they're NPO, you can just have them swallow their own saliva just to ensure that they are able to swallow. Going a little bit further into our sensory nerve function, here I'm talking about not just the head and neck area, I'm also talking about all of our extremities. So I want to assess sensation in all the extremities. So I'll hold my client's hands and say, can you feel which hand I'm holding? Again, with their eyes closed. Can you feel which foot or leg I'm touching? That sort of thing. If they're not arousable, they obviously won't be able to answer these questions. We won't be able to assess for sensation the same way. So this is when we will need to use some painful stimuli, where we're going to instill a small amount of pain and assess for movement in response to that pain. So if we see a client localized to pain or withdrawal from pain, we know that they are sensing that pain. Language-wise, like I said, we are assessing phonation and looking for things like word salad. Are they speaking in a confused way, which could be indicative of aphasia? We're looking for slurring or incomprehensible speech. Reflexes with our clients specifically who are lethargic, sedated, maybe we're sedating them, they're on a ventilator, we're going to assess some brainstem reflexes. And these are also commonly assessed when we're evaluating for brain death. So we're looking for a corneal reflex, cough reflex, and a gag reflex. The corneal reflex is assessing for a reaction to stimulation of the eyes. So in order to complete a corneal reflex, we're typically, again, doing this on a client who is sedated, either from our medication use, giving them medications to sedate them, or their brain function is at that point where they're really not arousing to much at all. At that point, they're usually on the ventilator. We have a sedated client who's on the ventilator. We want to assess for these reflexes. Again, this is typically when that arousability is really, really low. We're not even seeing a lot of movement in their extremities. So we will go through and assess these reflexes. The corneal reflex we assess by touching the cornea, which seems a little insane. You can do so with a cotton swab. You'll open your client's eye, use a cotton swab or a piece of gauze, and lightly stimulate that cornea, and their eyes should react to that. And start to kind of close as a protective instinct to the eye. I typically will do this with a saline flush. I'll just drop a couple drops of saline into the eye just because I get a little scared using a gauze pad on the cornea. I know that corneal abrasion is a concern. So you just want to have some sort of tactile stimulus on that eye and see if their eye kind of reacts and tries to shut. If it doesn't, they don't have a corneal reflex. A cough reflex we can look for by doing inline suctioning on their ventilator tubing through the ET tube. We'll stimulate the trachea by extending that suction catheter into their trachea, and that stimulation should stimulate them to cough. And a gag, we can suction the inside of their mouth. If we touch the roof of their mouth or the back of their oral cavity, we should stimulate a gag reflex. Those are the three main brainstem reflexes that we're assessing specifically in that client that has low arousability, that we're concerned for their brain function, or like I said, we're concerned that maybe we've over-sedated them with medication. We really shouldn't be sedating them to the point that they're losing these brainstem reflexes. And then just briefly mentioned down here, I also have included a respiratory assessment, gait, and memory. We're going to talk about respiratory assessment towards the end of this lecture. For gait and memory, if we're able to get a client up, we would love to see, again, is their movement symmetrical? And we can assess long and short-term memory by asking them specific questions related to things far in the past as well as things in the more recent past. Diving in a little bit deeper into our motor assessment, we want to assess our motor nerve function. So if your client is following commands, we'll have the client move all extremities and move against resistance and gravity. So typically, if I know my client follows commands, I'll first hold their hands. I'll say, squeeze my hands. Then I'll have them wiggle their toes. And then I'll go down to their feet and have them push against my hands like they're pushing on a gas pedal. And then I'll put my hands on the top of their feet and have them pull their feet towards the head of the bed against the resistance that I'm providing on my hands. We can do the same type of movements for their arms as well. So we want to see them move to command. We also want to see what their strength looks like. Because again, when we're concerned about conditions like stroke that have unilateral symptoms, we could see if there's a little bit of a strength difference when they are attempting to overcome resistance or gravity. Now, if your client is not following commands, we are assessing for movement in extremities in response to painful stimuli. And motor function can range anywhere from no movement at all to full movement against resistance. Now, I want to quickly talk about posturing here. Posturing is an abnormal finding that we see with brainstem lesion or severe metabolic disturbances. And it's something we can see in our clients that we are worried about brain death for instance. And there's three different types of posturing that I wanted to mention here. We have triple flexion, decorticate, and decerebrate posturing. And I just want to mention this because I want you as the ICU nurse, if you do see any of these posturings, to know, oh, this is indicative of something pretty serious. I'm going to alert my provider and have them come in and take a look. Or maybe I'll talk to my charge nurse and ask, hey, can you get another set of eyes on this to see if this client is looking like they're posturing? So triple flexion means that we're seeing, I don't have an image here for triple flexion, but what we're seeing is flexion of joints at three different locations. So we'll see a withdrawal of the wrist, the elbow, and the shoulder. Or if we're talking about the lower extremities, we'll see an ankle flexion, knee flexion, and hip flexion. Then there's decorticate, which I remember as the extremities are all moving towards the core. The elbows flex inward and the wrists pronate. And decorticate posturing is known as the worst type of posturing because it is typically always indicative of some cerebral or brainstem involvement. Once you're decorticate posturing, it's probably not due to a severe metabolic disturbance. We are talking about some sort of brain injury that has reached those primary areas. Then we have decerebrate posturing, which is away from the core, and this is when the extremities are extending and there's a pronation of arms. And you can see the difference between decorticate and decerebrate here. Next, let's talk about a pupil assessment. We're doing this on every single client in the ICU, taking a look at those pupils. Pupil size and shape. So they can range anywhere from 1 millimeter to 8 millimeters. We are looking at both pupils at the same time to see if they are the same size. And then we want to look at the borders of the pupil itself and look for an irregular shape or an irregular border. We are then assessing the pupil in reaction to light. So we'll use a pen light. Sometimes I use a flashlight on my phone, and you'll just introduce the light from the side, and you're looking for appropriate constriction and dilation in response to that light entering the pupil vision field. The pupil should have this reaction to light whether your client is awake or not. We'll do this very commonly on our sedated clients and ensure that their pupils are still reactive to light. When we're on a lot of sedation or narcotic medicine, it can make the pupil reaction what we call sluggish. And that means that we introduce the light into the pupil field, and it might take just a second for the pupils to constrict. And that would be a normal finding when we're on sedating medication. Then we can look at eye movement. It would be necessary that the client is awake for this assessment. We want to see if they're able to close their eyes and open them widely. Are they able to track appropriately? So if you're moving around, are they tracking your position appropriately? And when we give report or talk about our pupil assessment to the next nurse or to the provider, we will say that they are equal, round, and reactive, meaning we've got normal pupils. The sizes are equal to each other. They're both round with regular borders, and they're reactive to light. We can also call this PERLA. PERLA stands for pupils are equal, round, reactive to light, and accommodation. Now, it is difficult to assess accommodation in some clients in the ICU who are sedated. Accommodation means that the pupil will dilate for objects that are close by. Oh, fuck. Oh, I was wrong. Accommodation means that the pupils are going to dilate when they're looking at something far away, and they will constrict when they're looking at something close up. This would require that the client is able to look at something far away versus something near, and that would require being able to follow commands. We throw PERLA around a lot in the ICU with our sedated clients just to say like the pupils look good, everything's fine. But I do want to say that technically we don't know that the pupils are PERLA because we are not assessing for accommodation in those clients that cannot follow commands, which is a large portion of our clients in the ICU. Finally, here, I just want to touch on a respiratory assessment. Respiratory patterns do give insight into brainstem and cerebral function because that is where they are controlled. And we can see some commonly altered patterns that could be indicative of something going on with our neurological system. For instance, if we're noticing hypoventilation, this is typically indicative of decreased level of consciousness. There's another pattern called Cheyne-Stokes breathing, and this is where we see an increased rate and depth of breathing followed by periods of apnea. It's a very irregular looking breathing pattern, and it is indicative of cerebellar lesion. So we can use respiratory patterns to give, again, insight into any sort of neurological problem. Hi everyone, welcome back to the Critical Care course. This is Rebecca with Archer Review. We're continuing through the neurological module today, and we're going to talk about some diagnostic procedures that we see in neurological critical care. So let's get started with imaging. We know that we use imaging to diagnose a lot of conditions for all over the body, and the neurological system is no exception. So we do CT scans, MRIs, and EEGs, or electroencephalography. So a CT scan is going to quickly and conveniently image brain structures, and it shows hemorrhage, tumors, and structural abnormalities. I have here a quick reference for what different colors mean on a CT scan. CT scans are great because, like we said, they're quick and convenient. We can do a CT scan in just a few minutes. The client doesn't have to tolerate laying flat for too long, which with some of our neurological clients is actually quite a big concern because they might have evidence of increased intracranial pressure, which means we want to keep their head elevated to reduce that intracranial pressure. So we don't really want them laying flat for a ton of time. And that might be a contraindication to them getting something like an MRI done. An MRI takes quite a bit longer. It is used to image brain structures. It can show the presence of blood clots, aneurysm, hemorrhage, tumor, and fluid leaks. I didn't mention it here, but it also can just show infarct in general, so cell death of brain tissue. When a client comes in for a stroke, we will send them to a CT scan to rule out a hemorrhagic stroke, because CT scan can show us hemorrhage, but it's not going to show us necessarily an ischemic stroke. We're going to need an MRI to do that. Now, if we know our client is having a stroke, the symptoms are lining up, we rule them out for having a hemorrhagic stroke. We don't need the imaging verification to treat that ischemic stroke. We will go ahead and treat it, just knowing they're not having a hemorrhagic stroke, which we'll get into all of this when we talk about neurological disorders. But I wanted to point out a common reason why we will use CT scan versus MRI. Finally, here we have an EEG, or electroencephalography. This is to assess brain waves for seizure activity. This can be done as a one-time procedure, or it can be done continuously. Seizures must occur while the device is on, or it is no longer able to diagnose for seizures. At a few different hospitals, they don't have the capability of doing continuous EEGs, so they'll do this one-time procedure, but it's not always the most helpful thing in the world, because like I said, we need the client to actively be seizing while this machine is done for the brainwaves to be assessed, and they can see where those seizures are originating with this procedure. So a continuous EEG is much more helpful, because we can leave it on the client for 24, 48 hours. And if they have a seizure during any of that time, the machine will catch it and be able to assess those brain waves. Let's talk about a few invasive diagnostics. So first, here we have cerebral angiography. This is where contrast is injected into the vasculature, intracranial or extracranial, to show vessel irregularities. The provider typically is accessing through the femoral or radial arteries. Next, we have myelography. This is when we inject contrast into the subarachnoid space to assess the spinal cord and the vertebral column. And finally, here we have a lumbar puncture. This is where we are inserting a needle between L3 and L4, or between L4 and L5, and we are using the needle to aspirate CSF and then test that CSF. We're typically doing this procedure for bacterial meningitis as a diagnostic tool. And we will have the client in the flexed lateral recumbent position, which is side lying with knees flexed, or they can sit on the edge of the bed flexed forward for this procedure. Now let's talk about bedside monitoring. So these are the different things that we can do at the bedside, specifically in a specialized neuro ICU, to assess intracranial pressure, cerebral perfusion pressure, and cerebral blood flow. So intracranial pressure monitoring. We can do this through multiple locations: intraventricular, intraparenchymal, epidural, subdural, subarachnoid. Lots of different places that we can assess the pressure within the brain. Intraventricular is pretty common. We're going to place a burr hole at the cocher point to access the third ventricle. A catheter can then be connected to a drainage device to create an external ventricular drain. The client's condition and their ICP goals determine that drainage setting. How much CSF do we want to pull off the ventricle in order to reduce intracranial pressure? We are going to zero and level that device at the foramen of Monro, which is the auditory canal. We can also monitor intracranial pressure with an intraparenchymal fiber optic cable, and that's placed via burr hole as well, or during a craniotomy. Now let's talk about some ICP considerations. Normal is anything less than 20, and when we see symptoms of increased ICP, we're seeing headaches, nausea and vomiting, confusion, altered mental status, and weakness. Now that goes for a lot of different neurological conditions, right? So we are going to look at our client, see what they're experiencing. Did they have some sort of intracranial hemorrhage, maybe a brain abscess? Are they at risk for increased intracranial pressure? That will help us assess if that is where these symptoms are coming from. We can monitor cerebral perfusion pressure. We just need ICP monitoring to be taking place to do that. ICP measurements can lead to an estimation of cerebral perfusion pressure. We can do that using this formula below. Cerebral perfusion pressure equals MAP minus ICP. So if we know our MAP, which is our mean arterial pressure, and that we can get anytime we take a blood pressure on our client, let's say it's 70, but their ICP is 25, so it's a little bit elevated. That means our cerebral perfusion pressure is only 45. Normal cerebral perfusion pressure is anywhere between 60 to 80. So if we're at 45, we do not have enough perfusion going to our brain, and that is due to our elevated ICP. We can also do cerebral blood flow monitoring with transcranial Dopplers. That gives us real-time hemodynamic assessment of blood flow within the brain, as well as carotid ultrasound. This assesses those carotid arteries and ensures that they're patent, they're open, they're unobstructed, and able to send oxygenated blood to the brain. Hi everyone. everyone, welcome back to the Critical Care course. This is Rebecca with Archer Review. Today we're going to talk about neurological disorders in the ICU, and in this video specifically I want to talk about acute ischemic stroke. So we have two types of stroke, ischemic and hemorrhagic. So let's dive into acute ischemic stroke. These account for 88% of all strokes, and it's all caused by a blood flow obstruction. If we obstruct blood flow, then we are going to hypoperfuse tissue. So this is caused by a thrombotic or an embolic event. Thrombotic means it's a blood clot that is formed in the brain and is causing brain tissue hypoperfusion. Embolic means something has moved from somewhere else in the body and has moved to the brain and is obstructing blood flow, leading to brain tissue hypoperfusion. That embolic event could be blood, or it could be a fat embolism, or even an air embolism. So assessment-wise, what are we going to see when we assess these clients? We're going to see one-sided symptoms. That is a main factor of stroke. Any symptoms are present on one side. It's also common to see aphasia, which is not a unilateral symptom. Laboratory findings and diagnosis. We're going to diagnose by doing something called a stroke scale assessment, the NIHSS assessment, to be more specific. This assessment assigns a 0 to 42 score range, higher equals more significant neurological impairment, to assess for stroke symptoms. It's going to assess gaze, visual fields, extremity and facial movement, as well as sensation and language. As soon as we've got somebody scoring on this stroke scale, anything above 0 and we're concerned for a stroke, we are going to go straight to CT scan to rule out a hemorrhagic stroke. CT scan cannot diagnose an acute ischemic stroke. That has to be done with an MRI, but we know that an MRI takes a long time, and we don't really have time when it comes to ischemic stroke. We only have 4.5 hours to treat an ischemic stroke since the onset of symptoms. So as soon as that client has started to experience those one-sided stroke symptoms, we only have 4.5 hours from that time to administer a potent anticoagulant or clot buster to open up those obstructed blood vessels. So we don't have time to sit in an MRI for 45 minutes to an hour prior to giving that therapy. We simply want to go to CT scan. We know we're not going to see an ischemic stroke, but we will rule out that their stroke is hemorrhagic. If it's hemorrhagic, we don't want to give a massive dose of anticoagulant, right? We'll just make that hemorrhage a lot worse. So the priority is, hey, we know we've got a stroke. Our client has facial drooping, tingling on one side. They're unable to walk straight. They have all the signs of a stroke. So we know that they're having a stroke. So we just need to see, is it hemorrhagic or ischemic? As soon as we rule out hemorrhagic with that CT scan, then we can go ahead and manage that stroke instead of waiting for definitive diagnosis. So as far as ischemic stroke management is concerned, like I said, we must first ensure that this is not a hemorrhagic stroke. We're going to do that with a stat CT scan to rule out that hemorrhagic stroke, and that can be done usually in about 5 minutes. So it's very, very quick. Then the goal is to revascularize. So we're going to give fibrinolytic therapy, and that's typically done with the medication recombinant tissue plasminogen activator, or TPA. And we are going to give this within 3 to 4.5 hours of symptoms. It's not from when that client presented to the hospital, it's from when those symptoms started. If we don't know when they started, sometimes people wake up, for instance, with stroke symptoms. We don't know when their last known well time was. We cannot administer this therapy. It becomes a dangerous medication to give if it's been too long that clot has been there. It's not going to work. And then the risk of giving such a potent fibrinolytic therapy is too much for a medication that's probably not going to work on what we want it to work on. And I have it listed here again that we need to give a CT scan prior to administering this. If we give fibrinolytic therapy to a client who is having a hemorrhagic stroke and active bleed in their brain, that would be a potentially lethal move. We have to make sure they're not having a hemorrhagic stroke. Then, if we give that therapy, we continue to do neuro assessments, and we want to go to an MRI to assess for the extent of cerebral damage, then we can do that. Nursing management wise, after we give that fibrinolytic therapy or that TPA, we are going to continue to do the NIHSS assessments to assess for improving neurostatus as hopefully blood flow is restored to that area, that brain tissue can reperfuse, and function can return to the client. We also want to assess for worsening stroke symptoms. Because we're giving fibrinolytic therapy, there is a chance that we cause a hemorrhagic stroke in attempt to fix their ischemic stroke. So we need to do very frequent NIHSS assessments. After giving TPA, we're typically doing Q 15 minutes. So every 15 minutes, we're doing a stroke scale assessment on the client for 2 hours on that Q 15-minute schedule. And then it goes to every 30 minutes for usually about 6 more hours. And then at that 8-hour post-TPA administration mark, we will switch to every hour for at least 24 to 48 hours. In addition, we want to watch our client's hemodynamics. We want to maintain blood pressure under a systolic of 180. Hypertension in the presence of that fibrinolytic therapy increases our intracerebral hemorrhage risk significantly. Anytime we have high blood pressure, we are at risk for bleeding. So if we have high blood pressure and we are also giving fibrinolytic therapy or a strong, potent anticoagulant, then that risk for bleeding is only higher, right? So we really need to keep that blood pressure under 180 before and after this revascularization therapy. Hi everyone, this is Rebecca with Archer Review. Welcome back to the Critical Care course. We're continuing in the neurological module today, talking about neurological disorders. And in this video specifically, I want to touch on intracerebral hemorrhage as well as subarachnoid hemorrhage. So intracerebral hemorrhage is our other type of stroke, so different than our ischemic stroke. Description-wise, we're seeing bleeding of cerebral tissue leading to hypoperfusion and an increased ICP. That skull is a rigid container. So when we have bleeding present in the brain, we're going to see increased intracranial pressure because something's got to give. It's not a flexible container. This is most commonly caused by hypertension or an arterial aneurysm. Assessment-wise, we're going to see sudden headache that is so severe it sometimes can lead to nausea, rapid deterioration. This can lead to loss of consciousness very quickly. And we'll see severely elevated blood pressure, typically with a systolic blood pressure over 200. The brain kind of realizes that it's not perfusing well, and it sends messages saying, hey, we need more blood to the brain. Well, the heart responds to that by increasing cardiac output and increasing blood pressure. And that's really not what we want when we have an active brain bleed. We know that hypertension makes bleeding worse. We're kind of feeding that bleed with even more blood flow when we have a hypertensive environment. This is a bad compensatory mechanism in the setting of intracerebral hemorrhage. So how are we going to diagnose this? We're taking a look at those symptoms that the client is presenting with, and we are going to send them immediately for a CT scan. We know that CT scans can diagnose intracerebral hemorrhage, so that's all we need. Laboratory findings wise, I didn't even list anything here. We're not really going to rely on labs to diagnose an intracerebral hemorrhage. We need imaging. So we're going to go to that CT scan. Now, it doesn't mean that labs won't change when we have an intracerebral hemorrhage. What labs can we think of that might be affected? Well, we've got a bleed, right? So we're going to see a decrease in hemoglobin and hematocrit. But again, we're not going to wait on those labs to come back before we start treating this condition. We're going to go straight to CT scan. As far as the rest of intracerebral hemorrhage management goes, we are going to focus on our ABCs because we know that this client can deteriorate quickly. So airway, breathing, and circulation. Because of that loss of consciousness, these clients typically will require emergent intubation. We need to reverse any anticoagulant medications that they might have been on and reduce blood pressure to stop feeding that bleed with more blood. We want to lower our ICP because we know that this can increase intracranial pressure. So we might need to give some mannitol in order to do that. That is an osmotic diuretic, and it will pull fluid out of the brain. We want to maintain temperature under 38.5. Fever can commonly occur with intracerebral hemorrhage, and it can worsen the risk for brain tissue damage. And it has been proven that clients that did have a high fever in the early stages of their stroke symptoms, and that fever was not controlled, they had worsened mortality rates. So if we notice that our client is having a fever, we want to do what we can to maintain temperature in a normothermic zone, so not febrile. In addition to that, whether our client would be a candidate for a surgical evacuation of a clot. And I say clot here because once that hemorrhage has been present for a while in the brain tissue, it will start to coagulate and usually will then form a clot in the brain tissue. So that's what will end up being evacuated. Nursing management wise, we want to do frequent neurostatus assessments. This can be done using the NIHSS stroke scale, as well as going through just a full comprehensive neurological assessment. These clients do typically experience an increased ICP, so we need to do some ICP monitoring as well as some ICP lowering techniques. Those techniques include keeping the head of bed greater than 30 degrees to allow for gravity assistance. We want to keep the neck midline. If we have a client who is turned on the side, we can occlude some jugular veins that are responsible for draining the blood out of the brain, and that can lead to blood not draining out of the brain, and then it'll build up in the head and increase our ICP. Now, if that ICP is elevated and we need to treat that, we can give mannitol, like I said, which is an osmotic diuretic. We can give 3% saline. If we have 3% saline, which is a hypertonic solution in the bloodstream, it will pull fluid out of the cerebral tissue into the bloodstream and then out. Then we can lower our ICP that way. We might need to do a lumbar puncture to remove CSF. We can place an external ventricular drain in order to drain CSF from the ventricles and lower ICP. And we can also do a craniectomy where we take a portion of the skull and remove it. It's saved in a safe place for a little while just to allow an opening into that rigid case. So that way we can relieve pressure by opening up that rigid case just a little bit. We want to consider some common symptoms and implications. For here, I'm talking about stroke symptoms. That client might have difficulty communicating and swallowing, difficulty moving. That will provide implications to how we manage that client as nurses. So we need to consider, can they safely swallow? Can we give them a normal diet, or do we need to place a feeding tube? What functional things have been impacted by this stroke that we now need to consider as we care for this client moment to moment? Next, let's talk about subarachnoid hemorrhage. So this is bleeding in the brain as well, but instead of going into the brain tissue and the parenchyma, this bleeding is in the subarachnoid space. We talked about those meninges when we were in anatomy and physiology, and we have the skull, then we have the dura mater immediately under that skull, then the arachnoid mater, then we have subarachnoid space, and then pia mater, which goes directly above the brain tissue. So the subarachnoid space is sitting above the brain tissue but below the skull. Risk factors for subarachnoid hemorrhage are hypertension, smoking, alcohol use, and cocaine use. And typically an aneurysm is present from wall weakening, and that aneurysm then turns into a dissection, and we have massive bleeding in that subarachnoid space. We know that that subarachnoid space is highly vascularized. It's sitting right above that pia mater that has a lot of blood vessels in it. Laboratory findings and diagnosis. Again, here I've just listed a non-contrast CT scan. This will be definitive diagnosis for a subarachnoid hemorrhage. Labs may be affected, but they're not going to really help us diagnose this condition. We want to get this client to a CT scanner. Assessment: abrupt onset of significant headache, loss of consciousness, vomiting, and stiff neck. Stiff neck is what we call a cardinal symptom for subarachnoid hemorrhage. Stiff neck, or nuchal rigidity, is caused from irritation to the meninges, and we know that this subarachnoid space is sitting between two meningeal layers, the arachnoid mater and the pia mater. So it's going to be irritated by the presence of blood, and that will lead to that nuchal rigidity, or like we said, stiff neck symptom. How are we going to manage subarachnoid hemorrhage? Similar to intracerebral, it's important for us to support vital signs and assess our clients' ABCs, specifically if we are experiencing a loss of consciousness. We want to preserve neurological function, so we need to diagnose this and act quickly. Typically, we are going to intervene on a subarachnoid hemorrhage with endovascular coiling or clipping of an aneurysm so that we can occlude blood flow to that aneurysm, and again, stop feeding that aneurysm or split open vessel with more and more blood. We need to stop that bleeding process. When it comes to neurological function, the impacts will all depend on the location of the subarachnoid hemorrhage. Because it's existing between these meningeal layers, that pool of blood that is occurring there is just going to apply pressure to the brain tissue that's underneath it. So that pressure will lead to certain symptoms developing. Nursing management wise, again, with any neurological condition, we are going to do frequent neuroassessments as well as control our blood pressure. We have presence of a bleed, so we don't want to feed that bleed with more blood pressure. Goals are client dependent. Hi everyone, welcome back to the Critical Care course. This is Rebecca with Archer Review. We're continuing to talk about neurological disorders in the ICU today. and I want to specifically focus on bacterial meningitis in this video. So, a description of bacterial meningitis. We have an infection of the meninges. This leads to inflammation of the entire central nervous system. The prevalence of this disease has reduced due to vaccines, but we still definitely see it. And again, it's caused by an infection. So bacteria in the blood has crossed the blood-brain barrier. The blood-brain barrier typically reduces the incidence of pathogens making it into brain tissue, but it doesn't work every single time. Assessment-wise, we're going to see a classic triad of symptoms. This will include fever, stiff neck, and altered level of consciousness. Let's think about that stiff neck. We think back to subarachnoid hemorrhage. We know that was also a common symptom, and that stiff neck is referred to as nuchal rigidity, and it's caused by meningeal irritation, which we could imagine if we have an infection of the meninges, right? Other assessment details include headache and confusion that are common. Some lab findings and diagnosis. We are going to do a lumbar puncture for diagnosis of this condition. We need to evaluate the cerebrospinal fluid. If we see low glucose and high protein, that can be indicative of bacterial meningitis. When assessing the glucose in the CSF, we want to consider that CSF glucose in comparison to serum glucose. That can tell us if we're seeing low glucose numbers. In addition, we're going to culture that CSF and do a gram stain for bacteria identification. That is the diagnostic criteria for bacterial meningitis. Management-wise, it's important that we start immediate antibiotics. Typically, we're going to start with what's called empiric coverage while we're waiting for that CSF culture to come back and give us a specific organism. We want to get broad spectrum antibiotics started so that we're treating infection in general. And then when we know what the organism is, we can dial in those antibiotics. And then we'll also administer steroids to reduce inflammation in that meningeal space. Nursing management-wise, we need to do timely assessment of symptoms to ensure rapid treatment. If we notice these symptoms with our clients, we want to ensure we're getting that lumbar puncture as soon as possible and starting those antibiotics. Since we have to do a lumbar puncture when we suspect this disorder, we are going to assist the provider with that procedure. It's typically done at the bedside and will help with client positioning and comfort during the procedure. Hi everyone, welcome back to the Critical Care course. This is Rebecca with Archer Review. We're continuing to talk about neurological disorders today, and next we're going to talk about Guillain-Barré syndrome. So Guillain-Barré syndrome is something that people live with day to day, but they can have exacerbations, and that is what could land them in the ICU for treatment. So Guillain-Barré syndrome is a complicated condition with an unknown cause, but it leads to nerve demyelination. That slows nerve impulse conduction significantly as the disease progresses. It involves ascending peripheral nerve paralysis, which can acutely require need for mechanical ventilation in the setting of respiratory failure due to that paralysis. That specific condition is known as acute inflammatory demyelinating polyneuropathy. Wow, what a mouthful. Basically, it's saying that this is an acute condition. We have high inflammation in response to this demyelinating polyneuropathy that the client is already experiencing. So like I said, we're talking about an acute exacerbation of Guillain-Barré syndrome that does lead to such severe ascending paralysis that certain functions start to require critical care. Assessment-wise, we're going to see weakness and cranial nerve dysfunction. And like I said, that motor loss is going to ascend symmetrically. So mobility issues may be the first presenting symptom. Your client might come in and know they have the autoimmune disorder of Guillain-Barré syndrome. They notice that their legs are weaker, they're not able to move anymore, and then they see that ascending of paralysis. So laboratory findings and diagnosis, we are going to diagnose this a lot with clinical symptoms. And then we can do a CSF analysis as well. In the CSF, we're going to see elevated protein, but normal cell count. So how are we managing this Guillain-Barré syndrome exacerbation? So the disease course, it involves, like I said, this ascending paralysis, and then it reaches a 2 to 4 week plateau before we get a descending return of function. So through that phase where we have that ascending paralysis and that plateau, we need to support bodily functions. Specifically, if we're in the ICU, that's typically involving supporting the respiratory system as the paralysis has ascended to that point. And then as it starts to descend, we'll see a return of function. Maybe we can get them off the ventilator and let them return home. As far as treatment goes to progress these phases, we can do plasmapheresis, which is where we remove blood, separate the plasma from the RBCs, then we'll replace the blood with their own RBCs and a replacement solution. So we're basically taking the plasma out of their own blood. This is helpful in a lot of different autoimmune conditions. In addition, we can give IV immunoglobulin, which is IVIG, and these are antibodies infused to treat autoimmune disorders as well. Nursing management-wise, we want to facilitate rehab, ensure nutrition support during each phase of disease progression, and assist in pain control. Hi everyone, welcome back to the Critical Care course. This is Rebecca with Archer Review. We're continuing to talk about neurological disorders in the ICU today, specifically focusing on brain abscess. So description-wise, this is a necrotic zone within brain tissue that's from an infection or a trauma source. Assessment-wise, we're going to see a headache, level of consciousness changes, fever, seizures, nausea, and vomiting. Really, a lot of these symptoms depend on the location of the abscess itself. Diagnostically, we are going to look at a CT and an MRI to visualize that abscess. And typically, we do not need to do a lumbar puncture for CSF evaluation. That is rarely necessary, but it can be done when assessing a brain abscess. Medical management-wise, we want to manage with antibiotics and steroids. Intracranial pressure management may be required in settings of significant brain inflammation. There definitely can be inflammation present with brain abscess, so that can lead to increased intracranial pressure. Surgical options, we can do a CT-guided needle aspiration of the abscess, a craniotomy, or a burr hole, basically to relieve the pressure within the brain and drain the abscess if necessary. Nursing management-wise, just like any other condition, we're going to do frequent neuro assessments. Hi everyone, welcome back to the Critical Care course. This is Rebecca with Archer Review. We're continuing to talk about neurological disorders in the ICU today. And in this video specifically, I want to talk about cerebral tumor. So this is a tumor that is in the central nervous system, our brain. So assessment-wise, the tumor location can determine the specific symptoms. A lot of things in the neurological system are all controlled by location. So if we have got a tumor on the temporal lobe, we'll see different symptoms than if that tumor was on the parietal lobe, for instance. We can see seizures, headache, nausea, and vomiting, no matter the location of the tumor. Lab findings and diagnosis. This will be diagnosed with CT, MRI, and an EEG if we are in the presence of seizures. That is the tool that we use to diagnose seizure activity. Seizures are very common with cerebral tumors. So for that, part of the management of this condition is seizure management. We want to assess for seizures and treat them as they come on. Treatment usually includes an IV push of some sort of benzodiazepine, specifically lorazepam. Radiation and chemotherapy is typically necessary to reduce the size of the tumor, and in some cases, we can surgically resect that tumor. Nursing management-wise, it is key for the nurse to be aware of seizure precautions. So we're going to want to pad the side rails of the bed. In case your client has a seizure, they're less likely to injure themselves. And then again, frequent neurological assessments, which again is required with any neurological disorder. Hi everyone, welcome back to the Critical Care course. This is Rebecca with Archer Review. We're continuing to talk about neurological disorders today, specifically talking about encephalopathy. So description of encephalopathy has many causes. We can see hepatic encephalopathy, which is caused from elevated ammonia. We know that the liver is responsible for turning ammonia into urea. When we have a liver issue, it's not going to do that conversion well enough or often enough, so we can see an elevation of ammonia, and that can lead to encephalopathy. We can see anoxic encephalopathy from brain tissue dying, Wernicke's encephalopathy, which is from a thiamine deficiency and is very common in alcoholism, and hypoglycemic encephalopathy. What is encephalopathy? It's brain cellular death from lack of oxygen supply, glucose delivery impairment, or protein synthesis impairment. So basically, we're seeing brain cell death from these various conditions. Assessment-wise, it's not uncommon to see myoclonic activity or asterixis, which is jerking of limbs. And there is a Wernicke's triad of symptoms, which includes ophthalmoplegia with nystagmus. So it's a disorder of the extraocular muscles that control eye movement. So we're going to see reduced eye movement as well as nystagmus, which is involuntary eye movement where we see the eyes move side to side. We can also see ataxia, which is loss of muscle control, and confusion. With that ataxia, we might also see wide, uncontrolled gait. So laboratory findings and diagnosis, we're going to take a look at CT and MRI to rule out lesions or hemorrhage, because these symptoms could be caused by a lesion or a stroke. So we need to rule that out and determine that it's being caused by encephalopathy. We might put our client on an EEG, either a one-time or a continuous, if presenting with seizure activity. That way we can diagnose that activity as seizures and not something else. And in hepatic encephalopathy specifically, we will see those elevated ammonia levels that are causing these symptoms. So as far as management is concerned, it really does depend on the type of encephalopathy that we're seeing. So we might need to do targeted temperature management in the setting of an anoxic event. So this is for anoxic encephalopathy. We want to cool the client down so that their oxygen demands in their brain tissue are less and gives that tissue the chance to reperfuse and heal. This is very common in post-ROSC management. So that's return of spontaneous circulation. That's when we've done CPR and resuscitated a client. Then we determine they may have had an anoxic brain injury. We're going to do targeted temperature management to lower oxygen demands in the brain, allow for healing, and hopefully allow for this anoxic encephalopathy to resolve. We'll do seizure treatment if our client is presenting with seizures. Again, that includes benzodiazepine management typically. If we're in hepatic encephalopathy, we're going to administer lactulose for elevated ammonia. That is the treatment to get ammonia out of the system. And in Wernicke's encephalopathy, we're going to administer thiamine because it's caused by a thiamine deficiency. Nursing management-wise, we want to ensure that we've got seizure and fall precautions in place, as well as completing, you guessed it, frequent neurological assessments. Hi everyone, welcome back to the Critical Care course. This is Rebecca with Archer Review. We're continuing to talk about neurological disorders in the ICU today, specifically talking about status epilepticus. So I've mentioned that seizures can be a symptom of a lot of different conditions that we see within the neurological system. So let's talk about when a seizure just doesn't stop. The description of status epilepticus is 5 minutes or more of continuous clinical or electrographic seizure activity. So what that means with that clinical or electrographic just means that with clinical, it means we're visibly seeing that client seize for longer than 5 minutes, whereas electrographic will show us seizure activity that might not be visible to the eye. So that if we have 5 minutes or more of that electrographic seizure activity, that counts too as status epilepticus. Assessment-wise, we're typically seeing generalized tonic-clonic movement and altered neurostatus. As a client's actively seizing, they're typically not able to follow commands, answer any questions, do anything purposefully. So that's that altered neurostatus that we're seeing while a seizure is actually occurring. Lab findings and diagnostics, we're typically using clinical symptoms for diagnosis, and then we will get an EEG to confirm true seizure activity. We can take that client to a CT scan or an MRI to assess for the cause of that seizure activity. Do they have an abscess somewhere? Is there presence of a cerebral tumor? Is there a stroke present? What is causing this seizure activity? Management-wise, we want to ensure that we are evaluating their ABCs, especially if they're actively seizing. We need to do prompt anti-epileptic drug administration. These are those benzodiazepines that we're going to give IV push to try to stop the seizure activity altogether. If we find that a client is having frequent seizures or these really long seizures landing them in status epilepticus, that client may require continuous infusion of an anti-epilepsy drug following their event. Nursing management-wise, we want to ensure these clients are on seizure precautions. So padding those side rails, keeping suction at the bedside in case they were to vomit. We don't want them to aspirate. And we want to ensure that we are doing prompt treatment of seizure activity. So this includes ensuring that we have an as-needed order for one of those anti-epileptic drugs so that if we notice at the bedside our client is seizing, we don't need to wait for an order from a provider to be able to treat that seizure. We should have something as needed or PRN that we are able to give in the event that our client who is proven to seize can receive prompt treatment. Hi everyone, welcome back to the Critical Care course, specifically here in the neurological module. Today we're continuing and finishing up our neurological disorders in the ICU, Except in this particular part, I want to give a little bit of a procedure overview. We talked about a lot of different procedures when we discussed the management of different neurological disorders, but I want to circle back, go through them one more time so that we have a really good understanding of them. So a list of procedures here, I've included aneurysm repair, ICP monitoring techniques, craniotomy, burr hole, extraventricular drain, and ventricular peritoneal shunt. And I've kept the descriptions really simple and concise so that you have a good general idea of these procedures. So starting off here in aneurysm repair, we can do aneurysm repair either surgically or endovascularly. And that kind of goes for the whole body, by the way. We can do that with our central nervous system in the brain, as well as any other place that we've got a blood vessel aneurysm occurring. So surgical repair will require the provider to place a clip around the neck of an aneurysm to obstruct blood flow into that weakened portion of the blood vessel wall, which will hopefully prevent that blood vessel from dissecting and causing a bleed. Endovascular repair involves coiling the bulging area of that blood vessel, and we can do this again with endovascular management. So we're just going to enter through the femoral artery typically, and it's not as invasive as surgical repair. ICP monitoring. So remember, we've got a rigid cranium containing the brain, CSF, and blood. Normal ICP is less than 20. We can monitor ICP by using a fiber optic cable inserted into the parenchyma, which is the brain tissue, to measure pressures. If we do notice that our client has increased intracranial pressure, we want to instill some ICP lowering techniques, which include keeping the head of bed greater than 30 degrees, keeping the neck midline so that the jugular veins can drain blood from the brain, as well as maybe some procedures. So we could administer medications like mannitol, an osmotic diuretic, 3% saline in order to pull fluid from the brain tissue into the blood to be excreted later. A lumbar puncture to drain CSF and therefore lower ICP. We can place an extraventricular drain. We can do a burr hole to release pressure or a craniectomy. Let's dive a little bit deeper into those procedures. So craniotomy or a craniectomy includes removing part of the skull to release pressure. The bone flap that is removed is typically reapplied after that resolution of increased intracranial pressure. So it is retained. We're not removing part of the skull and throwing it away. It is retained to be replaced usually a few weeks after this ICP incident. A burr hole is a small hole drilled into the skull to relieve pressure. An extraventricular drain is a drain that's placed in the ventricle to drain cerebrospinal fluid, and it can also monitor ICP for us. And then we have a ventricular peritoneal shunt, which drains CSF from those ventricles, which are storage units of CSF, and deposits it into the peritoneal cavity. So it gets it out of the brain so that we can lower ICP. Hi everyone, welcome back to the Critical Care course. We're continuing in the neurological module today, talking about neurological medications that we commonly see in the ICU. So I want to get started here with anticonvulsants. These are medications that we are going to give for seizures or suspected seizure activity. The way these work are mostly unknown. They bind to SAV2 proteins, which leads to a decrease in vesicle release, which then leads to a decrease in seizure activity. Adverse effects, we're going to see fatigue, sedation, dizziness, headache, tremor, and depression and suicide. We want to consider renal function. We might have to reduce the client's dose for lower creatinine clearance numbers. So if they have reduced renal function, we'll typically give them a lesser dose. Medication examples include levetiracetam, phenytoin, and gabapentin. These are true anticonvulsants. So this is what we're going to give a client when they've shown that they have seizure activity. We will start them on a regimen of anticonvulsant medications. If your client is actively having a seizure, that's when we're going to use benzodiazepine management to stop that seizure in that moment. Next, let's talk about corticosteroids. We give corticosteroids anytime we're trying to reduce inflammation, which we might do to reduce ICP in brain tumor clients, as well as a few other different types of clients like bacterial meningitis. Mechanism of action. Corticosteroids act on glucocorticoid receptors intracellularly. This inhibits gene transmission for inflammatory leukocytes, and at high concentrations, it also inhibits B and T cells. That means we have anti-inflammatory and immunosuppressive effects. Indications when we're talking about our neurological clients is to reduce brain inflammation, to reduce ICP, typically in those brain tumor clients. Adverse effects are the same no matter why we're giving this medication. So it's osteoporosis or bone fracture, Cushing symptoms, hyperglycemia, which can lead to drug-induced diabetes, immunosuppression, gastritis, skin fragility, toxicity, and hypertension. So nursing considerations wise, we want to do blood glucose monitoring, given it can cause hyperglycemia. We want to check for taper dosing as this medication is weaned off. After prolonged use, we know that corticosteroids being suddenly withdrawn can be fatal, as the adrenal glands have not started to produce their own steroids if that client has been on corticosteroids for a long time. And we want to give oral doses with food to reduce GI upset. Some common medications here: in the IV form, we see methylprednisolone, and in the oral form, we see prednisone. Finally here, let's talk about osmotic diuretics. This is a very common medication to give in the presence of increased intracranial pressure. So mechanism of action: this decreases the blood viscosity and blood volume because it is a diuretic. It does not cross the blood-brain barrier, so it causes water to pull from intracellular space into the intravascular space and eventually out of the skull. That's why it's so great for our indication of increased intracranial pressure. Adverse effects: it's a diuretic, so it can cause dehydration and rapid fluid shift. Anytime we're seeing anything with fluid, whether it's diuresis where we're losing fluid, or we're giving a client fluid resuscitation and giving them fluid, we can have electrolyte abnormalities. So that is our main nursing consideration. We want to keep an eye on our clients' electrolytes. Example medications is mannitol. That is our classic osmotic diuretic that we will use for clients with increased intracranial pressure. Hi everyone, welcome back to the critical care course. In the neurological module, we are going to close out the neurological system today, talking about nursing and additional management of neurological disorders. So just kind of a catch-all for those disorders that we've already discussed. I want to start here just with a slide talking about applicable nursing diagnoses for a lot of our neurological disorders, just if you need some ideas for writing a care plan for a client with a neurological disorder. Next, I want to go over some seizure precautions. We talked a lot about seizures being a risk for many different neurological disorders. So what are we going to do for those clients that we're concerned may have a seizure? First, we want to pad the bed rails. They're going to have uncontrollable jerking movements of their extremities. We don't want them to hit a bed rail too hard and cause injury. We want to ensure we have suction set up at the bedside so that we can get rid of any vomit in their mouth if they were to vomit during a seizure and prevent aspiration. We'll keep oxygen in an ambu bag present at the bedside. And again, this is necessary for nearly all neurological clients in the ICU because so many different neurological disorders present a seizure risk. Quickly here, I also want to talk about one-to-one observation. We need to consider this need for our neurological clients. Behavioral complications due to brain injury can be common, and reorientation and safety can become difficult. So we need to consider the need for an observational sitter, which should be implemented prior to any restraints. We also need to consider the potential for violent behavior depending on the injury. Anytime we have a neurological concern, increased intracranial pressure, an abscess located on a part of the brain, those areas of the brain that control personality can be affected and make our client very behaviorally different than they would necessarily be at baseline. We see this a lot with clients with encephalopathy, where they're having that brain cellular death. That can present itself as erratic behavioral issues and potentially violent behavior. So we may need, again, a sitter to be one-to-one to keep that client safe.